So ML is a 42-year-old Pacific Islander female here at the clinic, 9 a.m., 9/28/2011, as a follow-up visit for her diabetes. She is here assisted by her sister, who is her primary caregiver. The history of her present illness is that she has had type 2 diabetes for the past 26 years with proliferative diabetic retinopathy. Her home blood sugar readings average 180. Her primary medical history includes schizoaffective disorder, benign hypertension, hyperlipidemia, type 2 diabetes, proliferative diabetic retinopathy, and she is currently up to date on her immunizations. Her family history: her sister states that ML has siblings and parents, both with type 2 diabetes. Her social history: ML requires a caregiver, and again, her sister is her primary caregiver. Her diet involves one large meal at night, often with soda, followed by a long period of inactivity. ML describes working in the garden with her sister, but does not enjoy this activity. She states that she quit smoking a few years ago by using the patch. ML's sister comments that she often requests cigarettes from her family members. The sister states difficulty in getting ML to be compliant with her medication at times, and also that she is very resistant to changes in her diet or exercise. The review of symptoms: the sister of ML describes persistent thirst, recurring infections, blurred vision, and increased fatigue and dyspnea. Vital signs: ML height is 5'2", her weight is 77.7 kilograms, her blood pressure is 128/82, her BMI is 31.28, which is categorized as obese, and her BEE is 1,600 calories per day. All of her metabolic panels are within normal range except for her glucose and her A1C readings. Her glucose was measured on 8/11/2011, it reads 141. Her A1C was measured on 2/28/2011, it reads 8.6. The history of those readings include 2/11 for her blood glucose and 8.6 for her A1C. On November 2010, she had a blood glucose of 169 with an A1C of 7.2. On December of 2009, she had a blood glucose of 190 and an A1C of 6.8. The physical assessment: she was alert, oriented to person, time, and place. She appeared generally nourished or slightly overnourished. She had no physical assist, no wheelchair, no cane needed. The metformin is also relatively well tolerated. Few adverse events or contraindications, as is the case with ML. And there are no drug interactions between this drug and her current medication routine. The current dose of 1,000 milligrams metformin daily is within normal range, which should be between 500 and 2550 milligrams. But it is not effective, as seen by her A1C levels not being within range. The oral route is appropriate for ML, as she is able to swallow pills. The interval frequency is not appropriate in ML. Her A1C levels and blood reading at home show that her blood sugar is not properly controlled. Fasting Comparison states that metformin is often and routinely divided into 2 doses, one in the morning before meals and one in the evening before meals. She is only taking it as a single morning dose. There are no signs or symptoms of adverse events of this drug. She does not show signs of lactic acidosis or hypoglycemia. The second drug that is used to control diabetes in ML is Novolog 7030. It is appropriate for type 2 diabetes in ML, as it is part of first-line treatment for managing type 2 diabetes once metformin has been introduced, according to the American Diabetes Association 2011 publication Standards of Medical Care in Diabetes. They also state in 2009 that insulin is the most effective treatment for lowering blood glucose levels, as it reduces A1C levels by 1.5 to 3.5%. They point out that long-acting insulin analogs may lower HbA1c levels more effectively than the intermediate-acting formulations such as Novolog 7030. The current dose of 25 units is not within normal range, which should be between 0.5 and 1 units per kilogram per day, totaling for ML 38 units. This is evidenced by the fact that her A1C levels are not currently within range. The subcutaneous injection route is appropriate for ML, as she has had no problems administering the injection. The frequency and interval is not appropriate in ML. Her A1C levels, again, and her blood sugar readings at home show that her blood sugar is not properly controlled, and Facts and Comparison states that Novolog 7030 is routinely divided into 2 doses, morning and evening before meals. She is currently taking Novolog 7030 as a single morning dose. There are no signs or symptoms of adverse effects of this drug. She does not show signs of hypoglycemia, hypokalemia, or any kind of injection site irritation. The therapeutic alternatives include the older class of sulfonylureas. It is a monotherapy that produces a decrease in A1C levels similar to metformin of 1 to 2%. The problem with this one is that they cause weight gain as well as hypoglycemia, so it is not appropriate for ML. The second class of medication is a newer class, the thiolidazine diones. Monotherapy with these will reduce A1C levels less than the other drugs. It will reduce it by 0.5 to 1.4%. It is also associated with increased risk of myocardial infarction, has high cost, and can result in an additional therapeutic alternative that has specific categories within it. Insulin in general. The 2009 Medical Management of Hyperglycemia in Type 2 Diabetes consensus algorithm for the initiation and adjustment of therapy by the American Diabetes Association and European Association for the Study of Diabetes states that there are several categories that can be used within the insulin category, including insulin regular. Their guidelines do not recommend using this. They have the rapid-acting insulin analogs, Aspart, glucosamine, and Lispro. These act more rapidly than insulin regular and have a lower risk of hypoglycemia, which would be desirable. The rapid-acting insulin analogs are shown to be superior to insulin regular, but may be associated with more weight gain. The intermediate forms, which she is currently on, include Aspart and Lispro. The problem with this category is that they tend to be less effective than a regimen that comprises a rapid-acting plus a long-acting, as they do not mimic normal physiological processes. And the final category of long-acting insulin includes Detamir and Glargine. These long-acting insulin analogs can be injected once daily, which would be preferable for ML, and they have been shown to be superior to the intermediate and the rapid-acting insulin. The interactions for the medications that ML is taking include 2 noted serious interactions. They are advised by Facts and Comparisons to use alternatives. For topiramate and simvastatin, topiramate will decrease the level or effect of simvastatin by affecting the hepatic and intestinal enzyme CYP3A4 metabolism. And for trazodone and bupropion, trazodone will increase the toxicity of bupropion by unspecified interaction mechanisms. It may also lower seizure threshold, so the bupropion is advised to be kept as low a dose as possible. The drug recommendations for ML include the following: metformin 1,000 milligrams once daily by mouth. ML is not at goal A1C levels, which should be below 7% for type 2 diabetes. Metformin should be given as a divided dose, but since compliance is an issue with ML, recommend the once daily 1,000 milligram metformin extended release version. For Novolog, 70/30 25 units once daily by sub-Q injection. Again, ML is not at goal for A1C levels for type 2 diabetes. Novolog 70/30 25 units should be given twice daily just before meals, but again, since compliance is an issue with ML, recommend the longer acting insulin glargine, which can be administered once daily. Dosing can start with 25 units, but should be monitored for needed adjustments up to 100 units daily. The drugs to avoid for ML include anything that will alter blood glucose levels. There are tests that are currently lacking to properly manage her condition. She needs to request an updated A1C before starting her new regimen, as the most recent one is from February. The goals we have for ML include the following. She needs to maintain A1C below 7%. To monitor, we will monitor with A1C testing 4 times a year as we have changed her dosing. Once stable, the A1C monitoring can go to 2 times a year. Additionally, we will request daily patient self-monitoring of blood glucose, and we will request the patient to return to clinic within 1 week with home monitoring values. Drug-related side effects to monitor for the new medications include renal function and hematologic parameters, which will be assessed by blood lab work, and that is just for metformin. For metformin and insulin glargine, there are side effects that are related that should be looked for. We will be able to have ML monitor for hypoglycemia by daily self-monitoring of blood glucose levels and by having her look for any of the following new symptoms: confusion, nausea, hunger, tiredness, perspiration, headache, heart palpitations, numbness and tingling, tremors, muscle weakness, blurred vision, cold temperatures, excessive yawning, irritability, or loss of consciousness. The patient education for ML includes the following. This is for the Metformin XR 1000 milligram tablet. ML, you will be taking a new version of your metformin pill that should help you better control your blood sugar. Take this Metformin 1000 milligram extended release tablet by mouth 1 time in the day at your evening meal. Swallow this tablet whole, do not crush it or chew it. Keep the medication in a cool, dry place, and you should avoid excess alcohol intake while taking metformin. For insulin glargine subcutaneous injection, you will be taking a new version of insulin injection that should help you better control your blood sugar. Take insulin glargine 25 units by subcutaneous injection once per day as you were taking your previous medication. This one you can take at any time of the day, but be sure that you take it at the same time every day. You do not have to inject before food as you did previously. Store your unopened insulin in the refrigerator. Once you open it, use it within 28 days, whether or not you have stored it in the refrigerator. Do not freeze insulin and do not use insulin if it's been frozen. For both of your new medications, metformin, extended release, and insulin glargine, 25 units. If you miss a dose of either of these, take the missed dose as soon as you remember it. However, if it is almost time for the next dose, skip the missed one and continue to your regular dosing schedule. Do not take a double dose to make up for a missed one. For both of your new medications, you will know the drug is working by your A1C levels and your blood sugar levels. We will monitor your A1C levels for you in the lab every 3 months. Your A1C should be under 7%. You should continue to measure your blood sugar readings at home, in the morning when you get up, and 1 to 2 hours after eating. Your blood sugar readings at home should read between 70 and 30 before meals and under 180 when you measure it 1 to 2 hours after meals. Although unlikely, you may experience hypoglycemia from either of your medications. The symptoms of this include nausea, hunger, tiredness, perspiration, headache, tingling, muscle weakness, blurred vision, low temperature, or irritability. Your doctor will tell you what to do if you experience these symptoms. He may tell you to check your blood sugar or eat or drink a beverage that has sugar in it, such as hard candy or juice, or he may tell you to get medical attention. If you have confusion or loss of consciousness, contact your doctor right away. Your diet plays a big role in helping you to control your blood sugar levels. The large meal you eat at night with soda makes it very difficult for your body to respond the way it needs to control your blood sugar. Eating smaller meals throughout the day without soda or perhaps with a diet soda will help you better maintain your blood sugar levels. And your sister has mentioned that she's asked you to join her in gardening, but that you do not enjoy this activity. Try to think of an activity that you would enjoy, and you can ask your family members. That way they can help you do this activity. It should be something that you enjoy, and getting in some form of exercise will help you keep your blood sugar levels under control. That's it.